Any of the judges?
Glaucoma and its correlation with histopathology of trabecular meshwork. We all know that primary congenital glaucoma is a type of childhood glaucoma that is associated with abnormal development of trabecular meshwork, and surgical treatment remains the mainstay of its management. We believe that better understanding of its histopathology may allow for a better targeted therapy in the future. However, the present literature is quite limited in this regards. So we conducted a prospective interventional study to evaluate the long-term prognosis of PCG and to correlate it with histopathology of trabecular meshwork. We included all the consecutive children presenting over a period of 1 year to our center with age less than 1 year, a diagnosis of PCG, and less than 2 years when operated. We included only naive PCG eyes who were not subjected to any ocular surgeries before, and all the eyes with coexistent ocular systemic pathologies, and children whose samples did not show evidence of trabecular meshwork and histopathology were excluded. So after obtaining a detailed history and performing a detailed general and ophthalmic examination, all the children were given a trial of medical management, and following which primary combined trabeculotomy to trabeculectomy augmented with mitomycin C 0.04% was undertaken. All the children were followed up for 1 year after surgery, and surgical success was defined as IOP less than 14 mm mercury at all follow-ups. The surgical specimens obtained during surgery were sent for histopathological examination. We limited our study only to the light microscopy, which was examined by one experienced ocular pathology and one experienced ocular glaucoma surgeon. So histopathological qualitative and quantitative findings included looking for presence of eosinophilic membrane, trabecular being arrangement, and endothelial cell morphology, availability of intervening spaces. Based on all these findings, our specimens were divided into low, moderate, and high cellular arbitrarily. So coming to the results now, we had more number of females in a study, and this was explained by variable inclusion criteria. 85% of cases had bilateral involvement, and 85% of them needed surgical management for control of IOP. IOP decreased dramatically from 29 to 13 mm mercury after surgery, with the maximum change occurring within first 1 month. Corneal diameters only changed insignificantly after surgery, with however the number of corneas that were actually hazy cleared up almost double after surgery. The cup disc ratio showed a significant tendency for reversal after surgery, and maximum changes occurred within the first 6 months. Surprisingly, we saw that our blebs had a significant tendency to change from well-formed type to thin cystic type, a finding which has never been reported before in any study, and we attributed this to a surgeon control factor, as all the surgeries were undertaken by a single surgeon. So coming to the histopathological results, eosinophilic membrane was appreciated in 35%, fused trabecular beams either partial or total were seen in 55%, and intervening spaces were seen in 60%. Pleomorphism of endothelial cells was appreciated in 25% cases, with maximum pleomorphism occurring in high cellular specimen. Although low cellular specimens are the most common in our study, we found that high cellular specimens were thicker significantly when compared to other specimens. So when we saw the fused trabecular beams, we found that they were associated with higher axial length and higher baseline IOP, while eosinophilic membrane was negatively correlated with the baseline IOP, and low cellular TM was associated with higher baseline axial length. Baseline IOP of less than 20 mm mercury was present only in 17% cases, and it correlated positively with trabecular meshwork thickness, indicating that thinner specimens had lower baseline IOP. So coming to the surgical success, we saw that whenever high cellular specimens were absent, the incidence of surgical failure was 0%. However, surprisingly, this did not correlate with quantitative endothelial cell density, where lower endothelial cells was expected to have a higher baseline IOP. So based on our findings, we can suggest that thick subcanalicular tissue in immature trabecular meshwork was responsible for severe early form of PCG in Indian eyes. According to Hollander et al., our eyes fall into severe goniodegenesis. However, further subclassification was difficult due to simultaneous presence and interaction of different histopathological changes, and various subgroup analysis did not allow us to have a significant p-value for classification into further subdivisions. Although eyes with more clear intervening spaces were expected to have lower IOP, no such thing was seen in our study, and this could be because the fused beams on the cameral side prevented passage of aqueous through these spaces. Lesser division of cells was more desirable than aberrant division, because latter culminated in thicker and pleomorphic trabecular meshwork, which was inefficient in controlling IOP both at baseline and after surgery. Major limitation of a study was that there were no controls, and association post-surgery were actually unreliable with the histopathological features. So we recommend larger studies to validate our results. From our study, despite its limitations, we can conclude that performing a light microscopic analysis of surgical specimens may guide prognosis of PCG, and further studies may actually help in designing targeted therapies aiming for an increase in trabecular spaces towards cameral side, and decreasing aberrant regeneration of trabecular endothelial cells may improve its medical management. However, presently we have to remember that maintaining a control IOP is more important than any other feature for control of the disease process in itself. Thank you. These are my references.